You have the floor to start.
Okay. Good evening, Prof. Good evening, senior consultants present, senior registrars. This evening we'll be discussing modified radical mastectomy. I'm Dr. Ismail Abdulmumin Ahmed, a senior registrar in general surgery, Federal Teaching Hospital, Katsina.
Well, I'm going to time you because I like to keep the time. So you have 20 minutes maximum.
Hello, sir.
You have 20 minutes to make the presentation. Let's go.
Okay, sir. And I'll be going through the following outline. Starting with introduction, talk about surgical anatomy, the indications, the contraindications, preoperative preparation, and then we'll be concluding, we'll be ending up with conclusion and references. As a way of introduction, modified radical mastectomy is a procedure in which the entire breast is removed, including the skin, areola, complex, the nipple, and most axillary lymph nodes. It simply entails total mastectomy with axillary clearance. It is one of the common.
Please change your slide.
Procedure done for locally advanced breast in West African sub-region.
Yeah, change your slides, please.
Form of history. French physician Lawrence in the 18th century was the first to advocate the use of axillary clearance for the treatment of invasive breast cancers. And later in the 19th century, sir?
Yeah, be changing your slides.
Sir?
Be changing your slides. As you talk, change your slides.
Sir, change it to what?
The next slide.
I think he has a very poor network. The network is slow.
Okay, that's what I can follow.
Yes, and his voice is breaking along.
So we're through with this second slide. But maybe we move on to the history.
Okay, sir.
So you speak now.
Okay, sir. Lawrence Henston, a German physician, was the first to advocate the use of axillary clearance as part of treatment for invasive breast cancer in the 18th century. Later in the 19th century, C.H. Moore, an English physician, re-emphasized axillary lymph node resection in the management of invasive breast cancer. In 1948, parties proposed the modified radical mastectomy. Scalon described his technique in 1975, and Auchinclock's procedure was accepted in the 1979. It was the most common procedure for breast cancers by American surgeons in the 1980s. Some modification or types of modified blocks. The parties entails total mastectomy plus removal of all 3 levels of the axillary lymph nodes and removal of the P minor muscle. The Scalon entails total mastectomy with the retraction of the P minor. Surgical anatomy. Okay, the breast is a modified sweat gland that occupies the anterior part of the chest wall. It extends from the second rib to the sixth rib, and then from the lateral border of the sternum to the anterior border of the axilla. It is a modified sweat gland and a complex tubuloalveolar gland that serves for lactation of the neonates, as well as an accessory reproductive organs in females. The breast has a number of glandular tissues surrounded by fatty layer, and then it's hello, sir.
It's the volume the people are talking about. Yes, speak as loud as you can.
Okay, sir. It's made up of glandular tissues surrounded by fatty layer. The glandular tissues forms multiple glands that secretes milks that empties into the lactiferous sinus and then subsequently into lactiferous duct, and lactiferous duct into the lactiferous sinus, and then finally into the nipple as milk leg down. It has two fascias: the superficial breast fascia, which separates the breast tissue from the subcutaneous fat over the skin, as well as a deep fascia. This deep fascia separates it sends down some septi called the Cooper's ligament. This Cooper's ligament anchors the breast to the underlying pectoralis major. There is a bursa which separates the breast from the pectoralis fascia, making it move freely on the chest wall. The blood supply to the is primarily by the lateral thoracic artery, the pectoral branch of the thoracoacromial artery, which are branches from the axillary artery. It also have branches from the second to sixth, the intercostal branches from the posterior intercostal arteries. It also have branches from the perforating branches from the internal mammary arteries. Venous drainage are into the corresponding veins, into the axillary vein, as well as the internal mammary, which empties into the subclavian vein. The axilla, it is the quadrangular space, which is situated between the upper part of the thorax and the upper limb. It has an apex that is directed cephalad and a base that is directed downward. The medial border of the axilla is formed by the lateral chest wall, and formed by some station of the serratus anterior, as well as the intercostal muscles and the ribs. While the anterior border is formed by the pectoralis major and pectoralis minor. Posteriorly, it's formed by the latissimus dorsi, the teres major muscle, as well as some part of the subclavius. Laterally, it's formed by the fascia over the axillary vein. The content of the axilla is mainly loose areolar tissue and mostly the lymphatics, which drains the breast and then cephalad into the systemic circulation. Of note is three nerves which are important here. The long thoracic nerve, which supplies the serratus anterior, the thoracodorsal nerve, which supplies the latissimus dorsi, as well as the lateral pectoral nerve, which supplies the pectoralis major. In relationship, the lymph node groups of the axilla are classified into level 1, level 2, level 3 by the relationship they have with the pectoralis minor. The pectoralis, those groups below the pectoralis minor are level 1 lymph nodes. Those behind the pectoralis minor are the level 2 lymph nodes. And those above and medial to the pectoralis minor are the groups level 3 lymph nodes. The level 1 lymph nodes include the lateral axillary lymph node groups, the posterior, the subscapular group, as well as the interpectoral group, all of which are the level 1, while the central nodes are actually the level 2 lymph nodes. Then the apical are the level 3. Indications and contraindications. Indications of modified radical mastectomy include locally advanced breast cancer, multifocal or multicentric breast cancer with positive lymph nodes, recurrence of breast cancer after breast conserving surgery, as well as inflammatory breast cancer. Contraindications include unfit, when the patient is unfit for general anesthesia, when there is metastasis, and then it's an unresectable tumor. then modified radical mastectomy is contraindicated. In pre-operative evaluation, the triple assessment of the patient needs to be done, which entails a clinical history, physical examination, investigation, as well as the histology. The clinical history involves taking a history regarding the pathology and its extent. The history of presence of comorbidities such as diabetes mellitus, hypertension should also be sorted out. Drug history, the current medication in which the patient is, which will affect the patient's example, example, blood thinners. Those blood thinners need to be stopped so as to prevent unnecessary hemorrhage. Now, on physical examination, general physical examination of the individual needs to be taken into account. Take into account the pallor, jaundice, as well as pedal edema. The cardiovascular system needs to be examined fully to assess the patient readiness for this operation, as he or she is going for a major surgery. The breast is to be examined in totality, as well as the axilla. The chest, abdomen, and spine will be examined looking for features of metastasis. Radiologic assessment include to assess the extent of disease. An ultrasound scan of the breast in the patient that has a voluminous breast, that means a breast with high density, or a mammography can also be done in a patient that has less tissue density of the breast. And then an ultrasound scan in a patient that has non-clinical palpable axillary lymph node. An ultrasound scan can be requested to confirm that the absence of axillary lymph nodes. Chest X-ray, abdominopelvic ultrasound scan, looking for features of metastasis to the chest, as well as that of the abdomen. A CT scan and abdomen can also be done. Histology is a must before modified radical mastectomy should be done. Investigations for surgery, a complete blood count, the urea electrolyte and creatinine, and then ECG if the patient is over 45, greater than 45 years. Then grouping and cross-matching of blood for safekeeping. Now, before the surgery, optimization of patients that present as an emergency with features of anemia, wound sepsis, and other comorbidities need to be optimized. It's correction of anemia by blood transfusion, control of wound sepsis by wound debridement, control of wound sepsis by administering of appropriate antibiotics, as well as correction, controlling comorbidities if present. Also, anticoagulants should be stopped. Admission, for those that have no indication for previous admission as an emergency, admission can be a day before surgery. And then consult to anesthesia should be sent for review. And then an informed consent needs to be taken, as well as consult to the plastic surgeon so that if the patient desires an immediate reconstruction, and then marking of incision sites can also be done a day before the surgery, or better still, a few hours before the surgery. General anesthesia with endotracheal intubation is the anesthesia of choice. Antibiotics is given to those who have a fungating mass. Under adequate lighting and appropriate instruments, 2 assistants are needed for the operation. Special instruments that are required for modified radical mastectomy include the Richardson retractor, which is this one displayed upward, and then the Freeman face lift or skin hooks, this downward, this image displayed down, as well as the electrocautery, the suction system, and then the standard mastectomy tray. It has artery forceps of varying sizes. It has sponge folding forceps. It has dissecting scissors in the form of Meisenberg scissor. The patient after anesthesia is positioned, and is positioned supine with the arm adducted at 90 degrees. The patient is cleaned, in which the hemithorax of the in which the procedure will be taking place is cleaned, including the upper part of the abdomen, the shoulder of the patient, as well as the arm of the patient. The axilla will be thoroughly cleaned and should be cleaned last. Then, after cleaning the patient is dripped. A stockinette is applied on the arm, is applied on the upper limb, covering the hands as well as the forearm up to the elbow. Then Four drips are applied, one underneath the hemithorax, another one over the patient, covering half of the upper up to the level of upper half of the abdominal wall, another one over the face of the patient, and another one on the contralateral breast, exposing the mid-sternal line as well as the whole of the axilla. The first assistant stays cephalad to the patient, that's over close to the patient's head, while the second assistant stays opposite the surgeon. The principles of incisions for modified radical mastectomy should incorporate the nipple areolar complex, the skin overlying the cancer with at least 2 centimeter margin. It should incorporate previous scar if present, and then should to close if feasible, easy to close if feasible. And the most common incision that is being done is the classical steward incision. The classical steward incision extends from the margin of the sternum to the anterior border of the latissimus dorsi. It comprises all the aforementioned principles. After an incision is made, flap is created, and the flap is raised. A subcutaneous full thickness flap is raised with extent superiorly to the subclavius, inferiorly 3 to 4 centimeters below the inframammary fold, medially midline of the sternum, and inferiorly into the anterior margin of the latissimus dorsi. After this creation of a flap will be done using the hook. The skin hook is applied on either side of the flap with at least 3 centimeters margin between them. Then it's raised, traction is being applied over it, and then a counter traction, it's being deployed by depressing the breast a little bit downward, clearly delineating a line, clearly delineating the subdermal plexus so as to make an appropriate thickness skin flap to prevent flap necrosis. This flap is being, creation of flap takes on circumferentially through the margins of which I've mentioned earlier to the subclavius superiorly, inferiorly 3 to 4 centimeters below the inframammary fold, medially to the mid-sternal point, and then laterally to the anterior border of the latissimus dorsi. After an adequate flap is being raised, the dissection of the breast of the pectoralis major is done. A sharp incision into using a scalpel is done on the middle end of the fascia over the pectoralis major. This fascia and the breast in totality is taken off the muscle, and in which the fibers of the muscle will be seen clearly without a fascia intervening in between. This dissection is started from medial and ends laterally towards the insertion of the pectoralis major muscle. After that, incision is being made. Axillary dissection now begins. The pectoralis major is retracted medially to expose the pectoralis minor and the clavipectoral fascia. The pectoralis here, after the exposure of the pectoralis major, the lateral pectoral nerve, which is the main nerve supply to the pectoralis major, actually runs just beneath the pectoralis major, between the pectoralis major and the pectoralis minor, and it's the main blood supply, it's the main nerve supply to the pectoralis major. So care should be taken so as not to damage this nerve. Then sharp incision into the clavipectoral fascia allow entry into the axillary fat and the contained nodes. Dissection is carried superiorly along the edge of the pectoralis minor to reach the inferior margin of the axillary vein. The aim of the axillary dissection is to reach the axillary vein, which is the roof of the axilla. Once the axillary vein is identified, it is followed medially to reach the axillary apex. The axillary content are then separated from the lateral thoracic wall, that's medial border of the axilla. Here, an individual will encounter the long thoracic nerve, which supplies the serratus anterior. So care should be taken so as not to damage the nerve that will lead to swinging of, or that will lead to winging of the scapula. Branches of the intercostal brachial nerve will also be seen crossing through the axilla and should be preserved if portions of the axillary vein allow visualization and the latissimus dorsi. Now, the axillary fat and nodal tissue between the long thoracic nerve and subscapular vessels is carefully dissected out and bulk with displacement, and careful pathologic examination for an axillary dissection will often reveal in excess of 20 lymph nodes. Wound is irrigated with saline, and then 2 drains are left in situ, one in the axilla and one under the skin flap. And wound is closed in layers, and then dressing is applied. As a way of summary, the 10th commandment of modified radical mastectomy are: drape and position the patient correctly, raise a flap of optimum thickness, dissect in a medial to lateral dissection and direction, and reach the lateral border of the pectoralis major. Find medial and lateral pectoral nerve and preserve them. Preserve and leave the pectoralis minor on its link. Dissect all level of lymph nodes if possible. Next slide, please, sir. Hello, sir. Can you hear me, sir? Okay, sir. Yes. Close the wound and leave half vacuum suction drains in situ. Next slide, please. Yes. Post-operative care include adequate analgesia for the patient, antibiotics in those that have a fungating mass, and then wound care. The wound is to be opened after 5 days if there's no pre-existing ulceration of the breast. And then wound care should also be done consistently. Drain care. Drain inserted will be monitored for effluent of the drain, and then it will be removed if serous fluid are drained less than 30 mL per day. And then limb exercises will be instituted. However, exercise should be of adduction should not be done until after 5 to 7 days post-operatively, because this might likely detach the wound from the chest wall, creating more space for development of seroma formation. So, next slide. Next slide, please.
Now hear you, Ismail.
Sir?
The slide has been there.
So there's the previous slide, please, sir.
Precisely, he bought it. You didn't see it.
Yes, sir.
Yes, speak.
Complications and management of complications. One of the complications of modified radical mastectomy is flap necrosis. Flap necrosis, repeat, flap is raised. A tooth lost is likely to be necrosed, as well as patients that have flap that is brought in under tension. Tension of the flap can lead to flap necrosis. An individual that have flap necrosis usually undergo debridement of the flap, as well as subsequent skin dressing, skin grafting subsequently. Wound infection can be a complication in the patient that has an ulcerating breast mass, ulcerating breast mass. If a patient already has an ulcerating breast mass, then the category of the wound is a dirty wound, and as such, it has a 40% risk of developing surgical site infection. Infection can be treated using the appropriate antibiotics after wound swab MCS. Seroma formation is the most common complication of modified radical mastectomy, and it can be reduced by the use of harmonic scapers during the development or creation of flaps. It can also be reduced by meticulous handling of flaps, as well as flap fixation. People that have patients that develop complications, that have developed seroma as a complication, application of compressing dressing can reduce the seroma formation. However, if it persists, aspiration can be done of the seroma, and sometimes even an incision can be done to relieve the seroma. Nerve injuries, specifically the long thoracic nerve of Bell, which supplies the serratus anterior, will lead to a deformity of the winging of the scapula. This is best prevented by this is best to prevent it than allowing it to occur. Also, nerve to the thoracodorsal nerve, the nerve that supplies the latissimus dorsi, is the latissimus dorsi muscle is involved in the overhead adduction of the shoulder joint. So injury to this nerve will lead to the deformity of overhead adduction. Lymphedema, it's a complication of modified radical mastectomy because the lymph of drainage of the upper limb goes through the axilla and then through the neck to the systemic circulation. Now, it is diagnosed when the circumferential difference between the gut difference between the two upper limb is more than 2 centimeters. And people that patients that develop lymphedema as a complication can be managed using a compressive stockings and sometimes an intermittent compressive devices. And local recurrence can be a complication. Next slide, please. Now, outcome of modified radical mastectomy depends on individual factors. The patient's considerations, the patient age, the stage of the disease. And then the long-term outcome is often positive with a reduced risk of cancer recurrence. Some studies have compared the outcomes of patients that have a axillary positive node as well as undergoes brain conserving surgeries and then radiotherapy. They found out that those that had modified radical mastectomy with modified radical mastectomy have least amount of recurrence compared to those that had breast conserving surgeries. However, this procedure can have physical and emotional impact on patients, such as change in body image and potential complications. Then, therefore, comprehensive care plan needs to be in place to overcome these challenges. Next slide, please. Follow-up of the patients, follow-up for late complication. One of the late complications of modified radical mastectomy is long-standing lymphedema of the upper limb that will subsequently lead to fibrosis of the subcutaneous tissue. And then it can also lead to lymphangiosarcoma. So patients that have modified radical mastectomy need to be followed up and then looked closely into this complication. And then also surveillance for tumor recurrence. The patients need to be assessed for tumor recurrence. Initially, it will be 3 monthly, then 6 monthly, then yearly for life. Next slide, please. Yes. In conclusion, modified radical mastectomy is a significant intervention used in the treatment of breast cancer. While it can have profound physical and emotional effect on patients, it is a crucial cancer recurrence. This decision to undergo modified radical mastectomy consideration the individual specific circumstances and preferences. Next slide. Next slide, please. So
The
here
next
are my
slide.
references. Thank you very much.
All right. Thank you very much, Dr. Ismail.
Thank you, sir.
Ladies and gentlemen, you have an opportunity to contribute in many ways, one of the several ways. Let's first give an opportunity. If you would like, you can send your comments in the chat, and we will take that, especially if your network is bad. Then you can raise your hand and we would allow you to speak. So the floor is open. I haven't seen any hand up yet, and nothing yet in the chat. As we said the last time, there are 2 hands up, two up for the time being. Dr. In that order, the way I'm just reading them, Dr. Eze, Peter Eze, and Ugochukwu, and then Agbola, Habib. We take them, don't make it like an essay, just deal with what you want to say, and then give others an opportunity to contribute also or ask questions. Right, so let's take these 3. Dr. Ismail, take note of the questions, and if they are just comments that are making, you will note. So let's start with Dr. Eze, then Ogochukwu, and then Habib. In the first round.
Thank you so much, sir. Thank you so much. Thank you so much, Prof, for this opportunity. Thank you, Dr. Ismail, for your very succinct presentation on modified radical mastectomy. I've learned a lot for your presentation. What I want to contribute is based on your incision. You mentioned the steward incision, which is the commonly used incision in modified radical mastectomy. And then there are other incisions like the Grace, the Greenup, the Cocas, the Oz, and the other incisions that are used for modified radical mastectomy. If you have given us these diagrams, it would have been okay based on the location of the lump in relation to the nipple areola. Then the other things include how do you know that you have raised an optimum skin flap? How do you demarcate the subcute from the breast tissue itself? Is it the nature of the fat that you see, and is there a plane between the subcute and the breast tissue that you can identify to be able to know that you have raised an optimum skin flap that will prevent skin necrosis and then also residual tumor in the breast. So, and you know that modified radical mastectomy is based on the way you treat the pectoralis minor, and then we have the pates, the scalon, and the arching clause, which we commonly use. So I normally code this with a PSA, the pates, the scalon, and the arching clause. And then this is either based on whether you excise the pectoralis minor, you incise it, or you retract it to be able to access level 2 lymph nodes. And that is the modified radical mastectomy. So you have said a lot of things on modified radical, which we have also seen, and we have learned a lot from your presentation. And I appreciate you for this very elaborate presentation. Thank you.
All right, thank you very much, Dr. Eze. He will respond to what you have asked. Let's listen to Ugochukwu.
Good evening, Prof. I don't know if I'm audible enough. Hello?
Well, we can barely hear you now, so speak because the network is breaking.
Hello?
We can hear you now, speak.
All right, sir. Dr. Ismail, thank you for the beautiful presentation. I'll make some comment and maybe one or two questions. The issue of incision has been taken care of. It was one of my worries. Please, I want to find out what is the role of the second assistant in modified radical mastectomy, because classically we perform this surgery with one assistant, but thanks for the information. I just want to know what is the role of the second assistant. Then, okay, as part of the instruments you made mention of, you talked about electrocautery, but you described the surgery and at no step you use the electrocautery. I know probably maybe because of hemostasis and maybe raising of flap, but my question there is that, do you raise flap with just electrocautery, or there are other means of raising the flap, of raising flap? And what is the benefit of one over the other? Or to make it easier, your flap you can raise using electrocautery, you can use harmonic stapler, you can use the code knife, which is the
Dr. Ogochukwu, I don't think the presenter is still with us.
Okay.
Just keep asking the questions we'll bring to him.
Yes, but okay. So Prof said you should continue. Well done.
Okay, so I just wanted to make it as a comment that for the raising of the flap issue, the instruments, he should be very clear. Is he using electrocautery, and which? Is he monopolar or the bipolar? Is he using a harmonic scalpel? Is he using a code knife or scissors? And the advantages of each over the other in terms of maybe complications, hemostasis, and duration of surgery. I think he was completely silent on that. For the wound, yes, some authorities are of the opinion that you should irrigate with, don't irrigate with saline, but you can use, I think, distilled water, because it's hypotonic and it helps in lysis of the cell, in addition to the mechanical means of reducing the tumor burden in the tumor bed by suctioning it out. It also help in the lysis of the tumor cells. Then the drain, also, he was silent on how to place the drain and the exit of the drain. If he's still with us, I would just want to make the contribution that if we are using the two catheters, ideally one should go to the axilla, then the other can lie over the P major muscle. Yes, there are negative pressure drain, irrespective of where you place it. By the time you charge the drain, it will definitely function. But you should exit the drain close, not too far off from the incision line, a little to the anterior axillary line or posterior to it. The idea of not placing it too far from the incision line is, if it's too far, sometimes during radiation therapy, it's like you've upstaged the disease. The area they are going to cover for their radiation becomes wider, and the oncologists are not too comfortable with that. So it should be as close as the incision line as possible, then maybe posteriorly towards the lateral chest wall. He also said something about more than 20 nodes for adequate axillary clearance. Well, I used to know for mastectomy 10, I think colonic tumors 12, then gastric tumors 15. That's how I coded it during training. But thanks for the information if this is the current thing. Then the entire mastectomy specimen itself, I think, is proper after excising it en bloc from medial to lateral with the axillary fat and the rest. It's proper to tag the flaps. You can tag the superior flap, tag the axillary tail, for a proper orientation for the pathology, so that they will be able to, because part of the things they are going to report is on your resection margin post-surgery. So that proper orientation is needed, so that you'll be able to know if you'll be able to achieve an RO1 or RO2 resection and it will also further determine your treatment, if this patient will have radiotherapy as part of your treatment or not. I think those are just some of my little comments and questions. Thank you, Prof, and thank you, Dr. Ismail.
Thank you very much, Ugochukwu. Ismail, I hope you are taking note. When you were out, we wanted to know how you handle skin flaps during dissection, whether cautery, and when would you use that, what the advantage and so on of using that, and using the knife, and using a cold blade, and so on. So you'll elaborate on that shortly. Let's listen to the third comment from Habib. Please make it as brief so that others who can contribute.
Yeah, good evening, Prof. Thank you for
moderating. And bring down your hand, Ugochukwu.
Good evening, Prof. Thank you for moderating this presentation. I think the presenter has done justice to the presentation. And I want to say that some of my comments are actually being raised by the last speaker. So some of the other comments I want to mention is that the presenter actually mentions that we should routinely look for the lateral and the medial pectoralis nerve. So I'm just I don't know, maybe that's what is actually advocated. I know in my center we don't routinely look for those nerves, except if it's seen, but it's not routine that we actually look for it. Then the other aspect I want to comment is on the aspect of excising the pectoralis fascia itself. Because I know there are many schools of thought. Some people say that don't excise the pectoralis fascia, while some people will advocate that you should excise it. Then some people will actually advocate that you should only excise the pectoralis fascia just around the vicinity of the breast and cancer of the mass itself. That's what most people advocate. So I want to ask if you can shed light on the pros and cons of leaving the pectoralis fascia or excising it. Then the other aspect is on the breast conserving therapy that you actually mentioned. I know there are many studies that are actually being done regarding comparing the modified radical mastectomy and the breast conserving surgery and therapy. And I think most studies actually mentioned that there's no there's no statistically different in the local recurrence when comparing both of them. But when we have to come down to our own sub-region, we realize that the radiotherapy is not readily available and it's not avoidable by most patients. Even those that will even benefit from breast conserving surgery, we end up doing a modified radical mastectomy based on their mentioned factors. I think those are my comments. Thank you.
Before Dr. Ismail, before you make the comment, another comments from Mutala Bello. I think that has been overtaken by Ivan. Partly, he wanted to contribute on measures for preventing seroma complications, and then also the current trends in MRM. And then he wanted to make sure to emphasize the need to label the specimen properly. That is very important. And then Mukailo is talking about, in addition to extend the upper flap, you said subclavius muscle, but subclavius is covered by pectoralis major. So could you like to comment on this quickly? Don't make it another presentation, just go straight to the point. Ismail, can you comment?
Okay,
yes,
thank you very much, Prof. Yes, sir. I'm having some difficulty with the network. I've gotten some comments. Thank you very much, Prof, and other senior colleagues for your comments and contributions. I think some of the questions I've put down on my sheets are, what is the optimum, how do you obtain an optimum skin flap? Now, an optimal skin flap should be of varying thickness depending on the depending on the physique of the patient. A very fat individual will have a subcutaneous tissue that is at least 1 to 2 centimeters, while a very thin individual will have a subcutaneous tissue that is less than 0.5 centimeters. So an adequate skin flap should be one that's raised between the breast tissue and the superficial breast fascia. This superficial breast fascia is usually identified because that's the point in which the Cooper's ligament that arise from the deep fascia inserts into the subcutis. So those are the things that will guide an individual, and then appropriate technique such as lifting up of the flap, and then the retraction, counter retraction technique have been shown to raise an adequate size flap. Then also, I also noted a question of what are the advantages of using either an electrocautery, scissors or knife in raising of these flaps. From what I laid my hands on, harmonic scalpels have been shown to be superior in terms of maintaining hemostasis as well as the speed at which a flap can be raised. There's minimal risk of seroma formation after surgery, as well as also a risk of perforation of the flaps. However, not all centers do have harmonic scalpel. In my center, harmonic scalpel is not available. And what we do often use is either to use an electrocautery or to use scissors. Scissors, it can be used to create a flap. However, it has the risk of more bleeding when compared to electrocautery. An electrocautery combines both your cutting as well as coagulation. So as such, it will be much more in terms of maintaining hemostasis, subsequent seroma formation, as well as the speed of the surgery. Thank you very much, Prof.
Okay. Dr. Ohia, you want to ask a question? I want to make a comment very briefly.
Thank you very much, Prof. No, just comments on
make it brief.
Brief,
so
yes.
So
on thank you very much for your presentation. On the preoperative preparation of this patient for modified radical mastectomy, it's always good to lay emphasis on, you talked about stopping the anticoagulants. Really, at this point in time, when we talk about enhanced recovery after surgery, you need to make a balance. So make sure the INR is being balanced. Even if you're going to stop warfarin, there's a room for you to either you give Clexane and make sure VT prophylaxis is being put on this patient because they already have a high risk of forming clots, and you're going to have a high problem of getting DVT and then PE at the end. So not stopping it, but making sure that that is being taken care of. With respect to drains, intra-op, two closed suction drains are very important. And the one you put in the axilla should be make sure that it's not too sharp. So you have to like bevel it so it doesn't make damage to the axillary vein, which is important. In complications, most of these patients usually have they stand a chance of having high risk of having dog ears to formation. So you can do a Y-shaped incision to take care of that, especially when you're doing that on the lateral side of the wound. And one of the complications again, which usually happens, especially when they're being put on a non-padded table, is brachial plexopathy. Yeah, when there's a lot of stretch over the arm, which could be avoided or prevented when you've had padded tables for the hand. And another one again is which it's now in vogue is although it's quite rare, is phantom breast. However, that could be taken care of by giving some good analgesia and then some things that can take care of neuropathic pain. Thank you very much.
Thank you, sir.
All right, thanks. Bash, you want to say something before I speak? There's a comment here by Abdul Majid. It's just about the definition of what modified radical mastectomy is. And block removal of the whole breast tissue, the tumor, the axillary lymph nodes. He would like you to take note. Bash, you want to say something before I make my own comment?
Prof, I noticed some other questions in the chat box.
Okay. Please, can you let me? I didn't look in. I would have seen that. Can you read out?
Okay.
Good. Another, I've just seen a question here now. It says, that's from Bima. Thank you for the presentation. What evaluations should be carried out during follow-up, following MRM? And then what is the thickness of the flap? I think you have tried to deal with that. Then two is about margins of incision. Some say 3 cm, some say 5 cm. Which one? And then this is a contribution of prevention of seroma. So yes, you can carry on now.
Hello, sir. Okay.
Yes.
Yes. The question of evaluation during follow-up, it entails the clinical evaluation, seeing the patient, basically taking into cognizance the recurrence, the scar, the axilla, examining the axilla, as well as the upper limb, the limb in which the surgery has been done, so as to identify lymphedema of the limb, and also to note other complications. Now, the imaging modality of choice for a patient to dictate early recurrence is a magnetic resonance imaging. That's the MRI. The MRI have the ability to identify early recurrence in the patient that had a previous scar of mastectomy. So MRI, it's advocated yearly MRI if it's going to be, if possible, coupled with the physical examination, as well as coupled with physical examination of the patient.
Okay.
Thank you, Prof.
Yeah.
Thank you, Dr. Ismail, for the presentation. I just have like few questions. What is the role of flap fixation?
Okay.
Flap fixation.
Yes, sir.
Then you did not mention, in some cases, you have to downstage these tumors. You are completely silent about your adjuvant chemotherapy before modified radical mastectomy, and several other questions have been asked. Then you also, most of my questions have been asked. Okay,
yeah.
so just tell us about about the flap fixation. Thank you.
Yes, sir. Thank you very much, sir. So what I came across about flap fixation, it has been shown to reduce the incidence of seroma formation in the patient that had total mastectomy. So that's in summary of what I came across. I don't know if there is more to it, sir.
Well, you are being reminded also that in the follow-up period, you are also checking the contralateral breast, not just the up site alone.
Yes.
So you
Yes, sir. Yes, sir.
Which is why
Yes,
even
sir.
preventive measures for breast cancer are administered, for the contralateral breast following the
Yes,
operation.
sir.
So you should take note
Yes,
of that.
Thank
Bash,
you, Prof.
any more advice from you? Any more?
Thank you, sir. So let's.
Okay. Let me make a few comments. I think you've done quite well. You gave us a historical account, an evolution of the various operative procedures and the rationale for coming to settle on ultra-close mastectomy for the time being. Let me say that you try talking about positioning of the patient, but when you want to expose the axilla, you put a small sandbag behind the shoulder, so you can open it much better. When we're doing this, we used to make sure that there is no infection. We used to actually scrub the axilla and ensure that someone is standing by holding the upper limb on that side, So you clean the forearm down to the axilla and the shoulder, and you drape before that arm is lowered. And then the hand is held in a sterile material, and the forearm and the hand are held in sterile drapes and then kept. And then you even clean the site again as to ensure that you have really taken care of, because this is supposed to be a clean surgery. If you are not doing it on an ulcerative lesion, it should be clean surgery. So you shouldn't be having an infection. Yes.
Yes, sir.
Now, I like the way you put it into various stages, you know, pre-op, intra-op, post-op, and follow-up, and so on and so forth. That is good. There were some few details of this operation that you didn't really quite talk about. That's why people are taking you to task on how to raise the flap and so on. Look, you can have one method you want to use, but I can tell you that many times you combine one or two approaches. If you have done diathermy, sometimes you don't even have diathermy. You may have to use both the sharp and blunt dissection to be able to raise your flaps. If you have diathermy, fine. If you have harmonic blade, then you are home and dry, much better. But this is the point. And let me also say that you talk so much about the nerves. For practical purposes, except you have a tumor that is fixed to chest wall or has some attachment seriously to chest wall, I don't bother myself checking for this. Or if somebody had gone to the axilla before, then they would have created a problem for you, because there will be fibrosis, and therefore it will be important to carefully seek out the structures and not damage them, the nerves, and not damage them. They were asking you about how to prevent skin necrosis. Yes, we dealt with one aspect. Let me be honest with you. It's sometimes a bit challenging not to denude the skin. But as you say, one traction and counter traction applied, it becomes easier to find a plane that you can easily go through and yet have some good amount of subcutaneous tissue to prevent the skin necrosis. Sometimes you don't have hooks. So lifting the upper flap with what? An Alice forceps, a couple of Alices would be an easy approach for you to do. So don't tie yourself to only a classical textbook description. A practical reality is also good.
Yes, sir.
And so I think intraoperatively you did. I don't normally irrigate, I must say, you know, but yes, people can do a lot of things. I'm not too sure how the scientific benefit of that. We have been irrigating the peritoneum, we've been irrigating every place, but Timo says don't just jump up and fall off, you know. Rather, they are left when you do not clear the surface sufficiently, not because of irrigation. And really, if you are removing the breast and you have attachment to the pectoralis or the pectoralis fascia, you are not very happy with it, then you take off those fibers and properly identify them by tagging so that they can tell you whether you carve all or not. It's important to prevent local recurrence by shaving off fibers of the pectoralis major if they are in your way. That is something. They're already taking care of the issue of the axillary nose, as you mentioned. And I'm very happy that a number of people drew your attention to surgical oncology, that you must label your specimens properly so that the histopathologist can tell you whether you clear sufficiently or not. Something you didn't mention here at all is that you should, if you have the facilities, you should have frozen section that can help you, facility can help you, you know, deal with the clear operation. You didn't mention about frozen section before. It's something you should not miss out. If you have it, you use it. If you don't have it, it's all right. Then you talk about closing the wound in layers. What do you mean by closing the wound in layers? How many layers are here really? I asked you that question because I have a technique of reducing the dead space by ensuring that at least some of this, the sutures I'm taking on the skin, take a little bit in that middle portion, they take a bit of the underlying muscle or epimysium. That helps to reduce the dead space further. But there's no question about it that the standard way of reducing dead space is to put in the vacuum drainage system. I'm not going to comment much about the flaps now, but I want to draw your attention to some complications that occur here much more often. Very terrible complication of injuring the axillary nerve vein can be really troublesome. And those tweaks, if you don't tie them well, you don't use diatomy there, you should mention that very clearly that we keep off in the axilla. Rather, you do a combined blunt and sharp dissection and so that all the vascular tweaks are ligated, not burnt off with diathermy. That way you would keep off injuring the axillary vein and the nerves. Now, you prevent local recurrence. I'm just mentioning about carving off the tissues of the epimysium or the pectoralis major and not really take about liberal skin that is involved. Once there is, for example, podorange, you must ensure that either you give downstage the tumor with chemotherapy or other methods before you come to operate, so that you do not have to leave skin that has tumor in. And post-operatively, how do you prevent flap necrosis? I'm sure that many of you have not heard of a T-board, but the bandaging of the patient post-operatively used to be done on a T-board. When you bandage on a T-board and you remove the T-board, very easily, the pressure of the bandaging is not too much because the T-board had taken up some of this stress. And that was what we used to make use of in those days. Hardly do you have a T-board now, but it's a very good device. And I will tell you about reduction of lymphedema, that you need to not only bandage the limb, but also elevate the limb on which mastectomy was done. Now, on a long-term basis, one thing you didn't mention, talk about lymphedema. Why does that lymphedema occur? It has many reasons. But one of the reasons is that there is some level of lymphangitis that develops. And if you do not pick out that lymphangitis, it will progressively worsen and close up all the channels. So in the post-op period, you must let your patient know that anytime they have pain over the limb with fever, they must get across to a medical person as quickly as possible to arrest any lymphangitis and therefore subsequent blockade of the remaining lymph channels. That's a very important thing. But I agree with you that you need to involve the plastic surgeons in managing if I involve them very early. And that's why somebody drew your attention. Before you operate, you should have taken the measurements to know what the mid-arm circumference and the mid-forearm circumference on the side you're operating. And that's part of what you monitor in the early post-operatively, so that as soon as that is beginning to develop, you will know and then take care of it. So the topic was not, it cannot be exhausted within this time. For example, we have not asked you in detail how you can, how long you will follow your patient up, how often you follow your patient up. You must have a definite approach of following up for the local side, for the distant side, for the contralateral breast. That's all part of follow-up of a patient who has had modified radical mastectomy. Now, the last point I'll mention to you is that you must see what the histology and the immunohistochemistry are of what you are removed before you say, yes, you can give your patient a long-term appointment, so that you would be able to tackle what needs to be tackled. You need to know the tumor margins. You need to know the number of involved positive axillary lymph nodes. And then you need to see the details, because what you got, I'm happy you mentioned histology before MRM and not cytology alone. Because when you get a histology, you look at the details. If you see The tumor looked apparently contained, but you find in your histology lymphovascular invasion and other tumor characteristics that show aggression. It means that
yes,
adjuvant therapy will also have to be equally aggressive.
yes,
And that's part of the follow-up of a patient with an MRM. I think I would like to stop there, but I've just seen somebody posted something about sentinel lymph node assessment. Yes, that is part of what one should add in deciding what to do. Just like I mentioned about frozen section, you can do especially when you are considering level 3 lymph nodes, you should, because when you remove level 3 lymph nodes, then you are also adding to the trouble of a lymphedema. And so
yes.
if it is possible, sentinel lymph node biopsy should be done to decide, in fact, whether you need to do the dissection or otherwise. But I agree with a very important point you raised, which is that if your ultrasonographer or sonographist, your radiologist is an excellent performer in checking lymph nodes, they will tell you, and I can tell you that in modern practice, radiologists can tell you what the state of lymph nodes are almost as if they are histopathologists, because there are a number of modalities that have been combined to give a fairly accurate status of lymph nodes, which is almost like histology. So if you have that facility available to you, you can decide on the level of radicalism you are going to apply to the modified radical mastectomy. So Bash, I'd like to hand over to you.
Thank you very much, Prof. We really appreciate your comments, contribution, and your untiring efforts for medical education. We also thank all the various fellows and senior registrars that participated and also contributed to the presentation. And also the presenter, Dr. Ismail, thank you very much for the presentation. Subsequent presentation will be announced and the link will be shared in due course. Thank you very much, everyone, for participating. And thank you, Prof, once again.
Thanks.
Thank you very much, Prof. Thank you very much, Prof.
Yeah. Thanks.
Yes, sir.
Bye-bye.
Good night, sir.
Good night, Raja. Thanks.
Thank you very much, Prof. Chubash, thank you very much.
Thank you, Amashew.
So, thank you very much, sir.
Thank you, everyone.
Au revoir.
Chief, thank you very much, sir.
Thank you.
Thank you very much, sir.
Thank you.